Okay, welcome back. We are cruising along this week, filming all kinds of episodes of the Pediatric Practice Media Cast. I've got Brandon on the camera with me. Brandon, say hello.
Hello there, interwebs.
All right, and with us today, our featured guest is Dr. Robin Warner, who is, as we just learned again, 15 miles south of Cincinnati in Union, Kentucky. She's got a couple
It's
interesting
exciting.
things to
We
talk
haven't
about.
had sorry to interrupt you. I just got too excited because Robin's here. I always get excited when we have a guest here. It's not just these two
Not just me.
ugly
Yeah,
guys that think that they know it all talking. Now we have a true perspective, right? A real anchor, right?
right. So say hello, Dr. Warner.
Hello.
All right. We're going to ask you a bunch of questions today about
Okay.
your practice. And the thing we were just talking about before I hit play or go or start here a second ago was the weather. Today is Valentine's Day. We happen to be filming today on Valentine's Day, 2014. And here in Vermont, when I got up this morning, we had about, I'm going to say, 8 inches, 10 inches of snow, which for Vermont is not a lot, but it's enough that things are getting shut down. My office is a ghost town. I know, Brandon, that the academy closed today. And so, Dr. Warner, you just told us that they closed schools for you today. And so this school closing and then therefore people not showing up at your practice thing is a big issue this year. We're seeing it quite a bit among our clients. I'm wondering if it's affected you at all yet this winter.
It has. More on the cold days than the snowy days, but yeah, business has been a little slow.
The thing that we're seeing is that not only do the cold days keep people from coming to your office, but it means when the kids are in school, they're not infecting each other.
Exactly.
So the sick visits are down. So is there anything that you do in your office to address that? Is that a big problem for you?
We actually try to do recalls on Well Child and get those in. If they're all
How's
still
that
they can
going?
come
Do
in.
you guys, when the schools close, do you kind of is that your cue to go ahead and close the office as well?
Oh no. No.
You stay open. You still come in.
I only live 2 miles from here, so yeah, it's no problem for me to get in.
What about your staff? Do your staff complain? It's like, oh, it's a snow day. Do we have to come in today?
Oh no. I only have one staff member and she's always here.
Well,
So
okay. So for you, it's not it's not an issue.
not for me.
You stay open regardless whether it's cold or snowy or whatever the case might be, huh?
What
Right.
happens, Brandon? What happens in your office? How often do you guys get closed?
So this year, this is the first year that we've actually had school closings for cold weather. We've never had that before, at least since we've been living here in Chicago. And we debated whether or not we should, because this is the first time where we had to consider this. But at the end of the day, what Joanna and I decided was that if somebody would brave the cold weather, we would rather them come see us than to go to a minute clinic or go to the ER. So if there was a mom out there, even if it was only one mom, and she felt that her kid was in bad shape enough to actually get in the car in that cold weather, we wanted to be the ones that were open. So what we decided was that we weren't going to close for the cold weather. And then the staff, some of them were like, our cars won't start and all this other stuff. And so we told them, I said, okay, it's up to you. Dr. Betancourt and I will be there. We will open. We won't ding you if you don't come in, but you do what is the right thing. You do what is the right thing for the practice, for yourself, for your family. And you just make the right decision, and I'm not going to ding you a day. But, of course, if you want to use a PTO day, you'll have to. I'm not going to pay you the day because, the office is open. And to our surprise, everybody showed up. And the very first cold weather day that we closed, we had 20 patients that day, which was, we thought we were going to have nobody or maybe 2 or 3. Granted, the schedule was a lot more full, but there was 20 patients that needed us, and we were there, and that's what the mission was, because the mission is to, is to be there, and so we felt really good about that. And in snow days, we haven't had a snow day this year. But in the past we've had, if it's really, really bad, and a lot of us don't live so close, we do, close the office just because it's difficult to get to the office, but not because of any other reason.
So, Dr. Warner, if if I'm just curious what your policy would be. I don't know, you know if you have one. Your practice is much smaller, so
Right.
policies are a little bit looser. But what if you were to close?
Mm-hmm.
What would you say to? Is it Holly?
Ollie. Uh-huh.
What would your policy be for Holly?
Honestly, since we're so small, I would go ahead and pay her, but we both live close and we have a pretty easy route to get here, so
Yeah.
practically it's not going to happen, likely, but I would
The-
pay her because it's going
One
to
of
be so.
the, yeah, one of the things I've seen on SOAPM this week is the debate about whether you pay people or not. And there's, I think, some real tension there because you don't want to have your employees make a dangerous decision to come into the practice. If they have no more time off and they can't use it to get in, or if their car is legitimately in for us in a ditch, what do you do?
Right.
So one thing I thought was clever, I think it was Kim Robbins out in near Seattle, South Seattle, out in Washington State. She was the one who suggested that what she does, and you have to keep an eye on your employee overtime laws, but she allows her staff, if they can't come in or don't make it in on a snow day, or if they cancel and they don't want to use time off to get paid for that time, if they can make up for that time within the next 2 or 3 months. Add a couple hours here and there, and then they get paid. And I thought that was a nice way of balancing the needs of the practice against the reality of the weather, and that's something to consider. But I know your office, Dr. Warner.
We in the days that we've had to close the snow day and we actually haven't opened the office. Obviously, if the office is open, again, I just said we give them the option. If you want to, if you think you need to come in, come in. If you don't, and then. But we're not going to ding you, or if you don't come to the office, don't bother coming back at all. We won't take that stand. We just tell them you use your best judgment. But on the days that we are supposed to be open and we've closed because of a snow day, we pay them half a day. We figure that it's not our fault. It's not their fault, so I'll meet them in the middle.
Well, I like that.
You eat 4 hours, I'll eat 4 hours, and it is and it is what it is.
Now, one thing I'm curious about, Dr. Warner, is, well, first of all, do any of the payers where you are pay for telephone codes?
No.
At all? No.
None. Mm-mm.
Yeah, I really see the future, especially with the weather getting worse in the wintertime. I really see a need for video visits. I mean, imagine if you could do a visit just like we're on right now. You could actually do a decent visit for certain things.
Right.
I'm curious. Here's a clinical question. This came up on SOAPM the other day. You've got a mom who calls. It's 5 o'clock on a Thursday. Her daughter's got a very sore red throat. The mom's a nurse, believes it's strep, but can't get into the office. What if you could fire up, Google Hangouts or Skype, or have her take a picture with her iPhone? In an emergency, would you consider doing something like that?
Sure. Yeah.
I think that's the sad thing is you can't get a 99213 out of that. At least I'm not aware of how you could do it. I guess this doesn't count as face-to-face yet, but that would make.
You would do it because do you think so? So, Dr. Warner, you would do it because you have a small practice, and I think you have a very, very good handle on all your patients. So, and if you know that the mom is a nurse or something like that, but so the relationship that you have with that parent perhaps is a lot more closer than otherwise. If you could, kind of extrapolate that in a larger office, and you don't know the patient all that well, and assuming that there's no HIPAA, let's just take all that away. No, I couldn't do it because of HIPAA. Okay, fine. Assuming that all that is good, and would you still consider that as something enough for you to make a decision when you have somebody on a video call to make a clinical decision?
Yeah, I think it's harder if you've got a bigger office and you really don't know all the patients. I used to work in a bigger office, so we would often get calls overnight, or after hours like that. It's tougher.
Yeah. So you wouldn't feel as comfortable, even if the video conference would be an option, and everything else being okay in terms of HIPAA, and this is a proper way. You would still not feel 100% comfortable.
Yeah, not as comfortable as I do. Right.
Well,
Not as comfortable as I do with my current
right.
situation. Yeah.
So it's a matter of the relationship, really. It isn't an issue with, with the technology you're seeing. It's more of an issue of do you have a good relationship with that family, right? I mean,
Right.
that's what we're going of it. So technically, you wouldn't even need the video phone call option for that example that Chip brought up, where if it's like the mom's a nurse and you know her very well and she's almost sure and she takes a picture of the throat and she sends it to you, you'd probably call it in as well, right?
Well, it helps to see. If they
Yeah.
can take a picture, that certainly helps.
Right. So I mean, it is not that this is something that you normally. I don't want to put you in a like, would you or would you not? Would you? But I mean, conceivably, it could be something that you perhaps would do, right?
Right.
Under the right circumstances, yeah.
Correct.
Right. I have a question for both of you, though. So on a bad weather day, and you get a pile of cancellations or no-shows, are you forgiving on days like this, even when someone doesn't call? Do you take the weather into account when your parents don't show up for back-to-back well visits or something like that?
Yeah.
If they don't, if they don't call, yeah, that's worse than calling and canceling. I actually had a double checkup cancel for this afternoon about 15 minutes before y'all called.
Yeah, but that's better that they called than just bailing out.
Right. Right.
Surely. And so now, do you have no-shows been a problem for you this year at all? Because depending on different parts of the country, I'm hearing about no-show problems, and we've been trying to measure it, but it's becoming hard for us to measure no-shows. The no-show rate. I'm seeing rates as high as 25% in some practices, which sounds crazy. But
why is it hard to measure, Chip? Why is it harder to measure the no-shows now?
Because not everyone records them.
Oh.
Some people.
That's a problem.
For example, when someone no-shows, they just sort of delete the appointment, which is not what I recommend. I'm a big fan of tracking no-shows.
Right.
So that's
we
the challenge.
Actually also we put, and I don't know, we always do this. At least the standing order is to do this, but because the systems are separated, and in case of Dr. Warner, it's not, so I'm not sure if that applies to her, but we also made it a point to document the no-show in the chart as well, because once you document it in the schedule, of course, the chart has no way of knowing that there's a no-show. But I think that clinically, it's always been important for us to know, especially when we print up the records, or when the mom calls for that refill. And then the doctor, because the doctor doesn't know if they no-showed or not, in a more busier office, they wouldn't necessarily always know. So we always thought it was valuable to also document it in the chart. And we just have like a fake encounter. We have Encounter Pro, as some people know. So we just create an encounter that's called a no-show encounter. There's nothing else to it other than just a description. But it's really interesting when you pull up the patient's chart and you see, that person has no-showed, several times. So then then when you're asking us, do we ding them? It's circumstantial. So if we see a chronic no-shower, then of course we'll take the measures. But if we see somebody that just no-showed once and it also happened to be a snow day, then we're not going to make a big deal about it.
Yeah. How about you, Dr. Warner?
Oh, with what?
With no-shows, what's your no-show policy?
Usually after we'll let them pass once. After that, we start charging them.
Okay. And are you able to collect the money from the charges? Do people pay it to stay in your practice?
Most of the time, they do.
And what do you charge? I have no fear of asking people these questions.
$25.
$25. Now,
I won't do that if it's just like an immunization visit, though. That seems to be our most common no-show, is just for a shot visit only. So that one I won't. But if it's a visit, yeah, we charge it.
Okay. And have you noticed an increase this year at all?
I have not.
Yeah, I'm trying to figure out what the patterns are. Why do some people have a higher no-show rate than others? And if you adjust it for payer or patient type, I'm still not seeing a great pattern. So it makes me think that there's something culturally within some practices that are more likely to get them than others. Like for example, if a practice routinely runs behind, it's a lot easier to no-show because you're like, well, it wasn't a big deal. They were, when they're 90 minutes late every day anyway, it doesn't matter. Now,
I think it's also in terms of understanding the no-shows. I think it would be worthwhile to know how they do their scheduling too, because we leave the majority of. I mean, I would say I don't know exactly, but I'm gonna throw a shot in the dark and say about 70% of our schedule is open when we open that day.
Yep.
And then we only book, like I said, 30, maybe 40%, depending on the physician. Each physician has like their own ratio. So, we tend to have less no-shows because the people that call, they called in that day. So I don't know if that would be an open access because it's not quite. I mean, we do have all the wellness visits already and then some of the follow-ups that are there. But a good portion of our schedule is already open. In other words, it's like not booked when we open the phone lines. So the thought, of course, is that if you call that day to be seen, the likelihood that you're not going to no-show is almost zero, right? Because you want them to be seen. Although it is funny, they do call, tell us they'll be there in a couple of hours, and then they don't show. So it's just like, what happened, But I think that maybe that's something to consider in terms of, if they're really, really booked, or they're not. Like we haven't seen any changes in our no-shows because I just think that the way that we book our appointments doesn't lead to a lot of opportunities for no-shows.
How about you, Dr. Warner? Do you have a sense of what your ratio is?
It's pretty low. I'd say 5% or less.
Yeah, and what portion of your visits every day are same-day appointments? Do you know?
Probably at least half. Right, this time of year. Yeah.
Yep. But at the same time, your practice is different from a lot of other practices, and in that you're not a concierge practice, but you are a very small personal practice, and it's not as though things like no-shows can go unseen, or it's not. You don't have a zoo. You have.
If they don't show up, we're calling them 15 minutes later, saying, "Where were you?" And sometimes they say, "Oh, we're on our way."
We're getting in the car right now.
Thanks for that reminder. I'm getting in the car.
Yeah, that's actually I really like that, calling people right away. I don't think enough of our practices do that. Now, Dr. Warner, do you? Because I know Brandon has something to say about this. He has something to say about everything, but he has something to say about this. But what do you do to remind your patients about their appointments?
Well, for well visits, we start calling about 1 to 2 weeks ahead of time to tell them to log into Chattis and do their Chattis.
Oh, okay.
We check every few days, and we bug the crap out of them until they do it, and we tell them it has to be done before they come in. So we probably call well visits at least 3 times to remind them.
That just makes me think of something. How often does someone complete their Chattis, their developmental screening online, and then not come in?
Very rarely.
I wonder that. I never thought about that. This is why Brandon and I do these things, okay?
Yeah.
Here it is right here. I've never thought about this. I wonder if Chattis has ever thought about how their process of pre-screening people before their visits actually contributes to a higher visit rate because it engages the family just before the visit itself. That's interesting. I wouldn't be surprised. Oh, Dr. Warren, I wish there were a good way for us to figure out your no-show rate for people who finish their Chattis reports ahead of time and the no-show rate for people who haven't done it. And I bet it's higher for the people who don't do it until they get into the office.
It makes total sense. It makes total sense.
Huh. That's interesting. So now, do you make? Does your office make the calls personally? It's like a person who makes the phone calls, right?
Uh-huh.
Have you ever used any kind of robo-dialer or anything like that?
Mm-mm.
Okay.
No, we're so small.
Brandon, in your experience, what happened in your practice when you used an automated dialing system?
Our no-shows increased. Nobody cared about our robocalls.
Now, do you have a sense? Do you have a sense if your robocall?
I don't know what the increase was. I don't know. I can't tell you what the percentage of an increase was. It was just a lot. I mean, it was enough for us to take notice. It was like, what is going on here? I mean, this is ridiculous. And I traced it back to like, wait a minute, when did we start making these robocalls? And
Right.
the robocalls, and we've experimented a lot with this. We've done, because I go to a doctor regularly, they call me like a week in advance, and that's the only call I get.
Right.
And I'm like, then unfortunately I got a phone, that I'm pretty good about putting my stuff in, because otherwise I would no-show all the time for that. They would have kicked me out by now if it had not been
Yeah,
for my
that's
phone. But we've done because we always tell people like, hey, if you can't make it, can you give us a call? And then there's this whole 24-hour thing, and it's just like, well, if we're calling the night before and their appointment is at 9 o'clock in the morning, when is it exactly that they're going to call us and let us know? So we did it. Well, okay, well, what if we do it 2 days in advance? So we've experimented quite a bit with this, and we still think that the personal phone call the day before gives us a much better, is our best results. Now, having said that, with this new little vendor that we're working with, not really worth mentioning right now, but it's a little vendor. They have a capability to do several things, among which you can do texting, you can do email, and it also does the robocall. So what we've done with them is we've set up. I wanted to do email. That was one of my things, the email. So we do the emails a few days before, and it has kind of like a hierarchy where, like, if it doesn't have an email, then it goes to the phone call, and if it doesn't go to the home, it goes to the cell phone, and then so forth. I haven't implemented the texting yet because I need opt-in and all this other stuff. But what I do is I think we do that like 2 or 3 days before the appointment. There's an email or a phone call that goes out, but we still call the night before. And that has improved tremendously, our no-show rates. Again, I haven't gotten to the measuring part of it, but again, it has been noticeably where we have seen our no-shows, drop. I wouldn't say dramatically, but improved as a result of us doing multiple, check-ins. And the great thing about it is that additional step is part of, the software does it. I love it when software does things for us. So we're still making the phone calls, but then that extra step is not really costing us anything, other than, well, yeah, I mean, it's a service, and you got to pay for the service and stuff. I mean, there's a cost associated, but in other words, in terms of manpower, or in my case, woman power, because they're all women. So yeah.
All right. So I'm a fan of at least just getting in touch with your patients in the first place. I think about, I don't know, 40% of our clients don't really do reminders at all. And I'd rather have a robocaller or emailer or texter in place than to have nothing. Always, obviously, a personal phone call is going to be more effective, especially because, I mean, there are a lot of systems out there, including the one that integrates with us, where the robocall can happen if the patient wants to reschedule right then and there. They can hit a button and the practice knows about it. That's nice, but that can never replace a real person hearing a tone of voice and saying, "Would you like to reschedule? It sounds like you might have trouble tomorrow," and then making that appointment right then and there. That's hard to replace.
I want to jump in real quick, and I haven't. This was a long time ago, but I think that it's worthwhile, particularly with the things that we talk about with our podcast in terms of the measuring. A few years ago, there was this issue about charging or not charging. So Dr. Warner does charge. We've never charged for no-shows, and the reason why, and I'll try to be as brief as possible, but being a data guy, being a guy that likes Excel and everything, I basically did a report on every single no-show because we do document those. And I also paired that up with the average, what was basically the average no-show rate for all of our patients. Coincidentally, I was taking a statistics class for my MBA, so it was a great exercise that I could show my class. So I had a fancy statistical, thing in terms of identifying with the bell curve on where everybody fell. When you, I think that the average person no-showed like 1.8 times, something like that, right?
Really?
Or
That seems
5
high.
times. It was kind of like a ridiculous, you know how statistics is. It's like, people, it's like 1.8. What does that mean? Is it 1 or is it 2? But whatever. The case is that there were the majority of the people, I would say nearly 65 to 75% of the people that saw us on a regular basis only no-showed roughly 1 time in a year. So I debated whether or not we should include a no-show fee to piss off somebody that normally comes to the practice anyways. Like I mean, I've been a no-shower from time to time too. So I'm like, was it worth implementing a policy and trying to collect that, sending out a statement and trying to charge $25? And then my second thought was, is the $25 really replacing the void of the visit? I mean, is that really, or is it just simply a penalty, or is it just simply a tax, or is it, what is it exactly? Because my view, if you're averaging 120 or 100, $100 a visit, then at the very least you should charge $100, not anything less, because that's truly what you are not making. So, and I didn't feel comfortable charging $100 and plus dollars for a no-show, because people were gonna, who's gonna pay $100 for a no-show, right? So, and then I sliced them up, and then the recurrent offenders, I just decided to deal with them individually, not do a blanket statement. So I said, hey, anything more than, I don't know, I think it was 3, you're out. I'm not asking any questions. I don't care, whatever. You get a letter and you're dismissed. And then there was another portion that did no-show like 6 or 7 times, 8 times, something like that. There were like 3 or 4 patients that did that. When you look closely into those patients, these patients, how can I describe them? They were like our most demanding patients, both clinically, behaviorally, socially. In other words, the rules did not really apply to them because there was all kinds of craziness attached to those families. Like I said, I mean, the kids were, high maintenance kids, all kinds of clinical complications, social issues, transportation issue, income issues. I mean, so for those, we weren't going to dismiss them because we were the only practice that would take them, quite frankly. I don't think anybody else would. So my point with telling you this story, and I think you're going to love this, Chip, because this is right up your alley, is that the decision that I made was based on the data that we collected, and we keep on going back in discussions in terms of making decisions, as opposed to, I get a little gut feeling here that I think that we're getting a lot of no-shows. Let's just put a $75 charge to this. Well, wait a minute. Let's look at this, and that might be true, but let's go down this route. And once you go down the route, at least I made a decision. Whether it was I felt comfortable with my decision because I had data to back it up, and I think that that's really the message here in terms of whether you should charge or not charge. It should not be just simply, damn you patients, you're wasting my time, but to be a little bit more objective, if you will.
Right. Well, the whole goal is to reduce your missed appointments. So whatever your particular patient constituency responds to is what you need to use. And obviously, there's never, for any practice policy, one size fits all. Is always going to be dangerous. All right.
The other
so
thing is,
event,
one last thing is that when you're fairly busy, I almost view no-shows as a blessing because it gives us an opportunity to catch up.
That's why no-shows in practices that run chronically behind are the patient's way of telling you that you're not doing it right. So,
but there's always an opportunity to do something else. I mean, if you're a specialist and you only see 4 patients a day and 2 of them no-show, then you got a problem. But
if you're a specialist who sees only 4 patients a day, you can afford some no-shows. That's my perspective. But all right. So in any event, when it comes to no-shows, the reason we even brought this up is because I've had a lot of people ask me about it lately, and the bottom line is, in my opinion, that there's no substitute for personal touch when contacting your patients. I think Dr. Warner said it most scientifically when she said you bug the crap out of them. I think that's the technical term.
If they don't call us back, we text them. So.
All right, there you go. So I know from very, very limited measuring that at the top of the list of effectiveness, now this isn't exclusive, okay, but the top of the list of effectiveness is a personal call. The second most effective thing is a text. The third is an email. The fourth is a postcard or a letter.
But we'll even have them program it into their phone too.
Yeah. So
next appointment, say, here, let us put it in your phone for you.
Dr. Warner's giving us here some stuff that I think, and I think you're picking up on it too. But we've talked about this independent physician trend and everything else, and how you're not going to survive if you're not part of a large group, and this doom and gloom. Now, what I'm hearing from Dr. Warner is a service that only she can provide. So if I would be a betting man, I would say that Dr. Warner is going to be just fine with this doom and gloom scenario, moving forward, just based on the stuff that I'm hearing. Are you catching are you picking up what I'm putting down here? I mean, I just think that this is awesome what I'm hearing, and this is the thing about offering this type of personalized service, that there is always going to be, like, she doesn't need to see 10,000 patients, right? She's a solo physician with 1 or 2 employees. How many possibly patients can you physically see? I mean, there is a limit to that number, and that's all you need. And that personalization that I'm listening to, there's got to be something to it where people will always there'll always be somebody out there that will appreciate that level of service. So I wanted to ask Dr. Warner about her thoughts on a solo physician, why she hasn't, and I might have already answered the question, but you know, you said you were part of a bigger group. You went to, just tell us a little bit your story. I guess let's start there. Tell us your story.
Oh, I've had 4 or 5 jobs. I started out of residency in a group, left that group in Florida and moved to Atlanta and did urgent care with the Children's Hospital there for a few years. Then went to another group, and then family issues arose, and I ended up where I am now with a multi-specialty group, well, primary care, family practice, and pediatrics, and I worked with 6 or 7 other pediatricians, and it got to the...
love that scenario, I would imagine.
No.
I love working there.
No.
It was ideal, right? A lot of people to share calls with, right? I mean, it just sounds perfect.
That was probably the only benefit, sharing call.
Okay.
But,
you know, obviously, tongue-in-cheek, for those of you that are listening and not watching me, I mean, I'm trying to be funny here because it's just not the scenario that she wanted, because you went out and did what?
Because 6.5 years ago, I went out on my own, opened my own practice. The multi-specialty group said, you know, we're family practice. We really don't know if we need peds or not, so we're just not going to support you that much.
Do you have, like, was it, I mean, is there some way where you can kind of describe kind of like the one thing that said, you know, this is why I'm leaving? I'm sure there were multiple things, but, like, what was it exactly that said, you know what, if I had to encapsulate it all, here's the main, you know, in a one sentence kind of thing, why I decided to go solo?
It was, well, 2, lack of support from the administration and not sharing the same
values,
treatment plans, things as the other pediatricians in the group.
So not only were there clinical discrepancies, but also from an administrative standpoint, you didn't agree. So there was on right. Both ends. Okay.
All right, so let me ask
6 years ago, you started your own practice. Now, by this time, you know, most people would have already perhaps added somebody else. But it seems that you're very happy with your current circumstances. Can you tell us a little bit about your thoughts on adding or not another physician or an NP or whatever, you know, whatever the case might be?
Yeah, I keep the volume comfortable for me, so I don't need anybody else. Like I said, the big thing is just vacation coverage. That's probably my big issue. Yeah. Yeah, and even when I'm on vacation, I actually take my own call unless I'm out of the country. So it's, you know, my family.
This is a purpose-driven kind of effort in terms of keeping that volume low, precisely so you can have the type of lifestyle that you want. Right. And my assumption is that you also practice, you know, you don't give a rip about anybody else. You practice exactly the way that you want to practice, right?
Right.
And
right.
third,
families know that coming in. I tell them, I'm it. You know, this is my vaccine philosophy. In fact, we tell them straight, we won't even see them. If you know, as far as vaccines go, we're a vaccine only. If they don't want to vaccinate their kids, then they don't even get through the front door.
That decision. Now, these things that you're saying about, like, you know, bugging the crap out of them, and then you would even take the phone and actually put it in there. Would you say that that's is just something of a core value that you have in you in terms of how you like to practice medicine, or what you think medicine should look like? Or was this a little bit more deliberately in a sense where I'm creating a differentiation, you know, more like a marketing type of initiative, where it's like, these are the things that I'm only able to provide that the Minute Clinic won't be able to, and certainly the large multi-specialty group can't either?
It wasn't marketing. It was just making sure that they were organized and they knew, you know, what was expected of them, kind of teaching them responsibility.
Okay. So, in other words, it's you showing them, what's the word that I'm looking for? Care?
Uh-huh.
All right. Now, Okay. So I've heard that I've heard really cool things that you do just right now, and I have this other thing that you have kind of insinuated, and you've kind of teased me about on something that you have been working on. I know that Chip has been involved in it. So can you tell us a little bit exactly what you have planned in terms of something really cool that you're working on, and it's just about to be launched. So tell us a little bit about the project, the genesis of the project, why you're doing it, where it came from, perhaps what your goal is, while you doing it, and so forth.
Well, I am launching a patient loyalty program. And
What? Wait, back up. Is this like one of those things where the more times I go, I get my little thing, and then I get 10% off my next ice cream, or I get a free appetizer if
like that. But it's for simple things. It's for if you bring your insurance card in, you're going to get a little point. If you fill out your Chattis online ahead of time, you get your points. If your kids are up to date on shots, they get their points. If you come in for your annual well child check, you get points.
Wow, that is. So I need to wait 1 second. I need to process this for just 1 second, because obviously this is very, very customary in like what I just described. Whether you go to an ice cream store on a regular basis, or your favorite breakfast place, or heck, even the grocery store will ask you for your little loyalty card thing, and they'll give you a discount. So how did you come up with this and take it from? I mean, did you see like the other companies did it, and then say, how can we fit this into a medical practice, or it was just like, well, this is easy, this would work perfectly in a medical practice? Like, tell me a little bit about that.
Oh, it wasn't easy, but yeah, I got my inspiration one day looking at my keychain and seeing all of my my loyalty card.
Okay.
And we knew we needed to make some improvements in the office, especially since we just launched Chattis. We were having trouble getting the teenagers to excuse me, fill theirs out. We were having trouble with HPV vaccines, so we made that a measure for the teenagers because they get their own little loyalty program. And then,
okay, go ahead.
And then we've also got chronic disease program for kids with asthma, ADHD, and other chronic illnesses, where obesity, where they'll get points as well.
Now, how do you measure that? I mean, this sort of thing. Do you have a piece of paper at the front desk, and Holly writes down this person checked in, or how do you go about tracking this stuff?
Well, we have a list of our points, and then I got a really cool app.
Ah, an app.
An app.
You're one of those trailblazers, and those crazy young kids that are using all these apps. So, for those of you that are listening to this and not watching, Dr. Warner is actually showing us the app on her phone. So you created your own app.
Uh-huh.
And my guess is that you tell people, download this app. Do you charge for the app? Is it a free app?
It's a free app. And it's actually
okay.
Out of, Australia, but this is what one of the reward programs looks like.
Awesome, awesome. So people, when they come in, and then they come in, so they fill out their Chattis, so they mark off, they filled out their Chattis, and then they get a.
We know ahead of time
right?
They fill that out because it's online, so we'll have that record. But then we just this little stamp here, and there's a little section that says "Stamp Me."
And then, of course, only you guys can stamp it, or is this kind of like on an honor system?
Only we can stamp it. Yeah.
Yeah. Oh, awesome! I love it.
And then once they get to 20 stamps, they go into a raffle for a gift card each month.
Yeah, and that's what I was going to say. Like, what's the what's the reward? But the reward, Chip, this is unbelievable. Why? I mean, Chip is so dumbfounded that he hasn't even said anything. He thinks this thing is so great. Chip, this is what I see with this sort of thing. One, I don't even know where to begin, but one is using the app, using this whole app craze to leverage this. Second, motivate your patients to do a game, essentially, right? Do a game that the more you do, the more points you earn. So it's a gamification, which is what we've kind of briefly discussed here. But at the same time, what I love about this is that, and I love it that it's free, because at the end of the day, it's getting people to do the stuff that they should be doing anyways.
Right.
Being proactive with their health care, which is the role of who? Primary care physicians, right? but you're doing it in a fun, unique, very creative way. I mean, I don't know what better way to be. As we all know, preventive medicine is the best medicine, and you're using here almost a little game, almost using the same thing that people with the Candy Crush, mentality have, or the what was that other one, the Farmville, kind of using the drive that people have to beat the score and to do better, and to using that's in us to really motivate them to have a better lifestyle, because of course they have to do certain things, and you have other stuff in there about doing things so they can be prepared when they come to the office, and you can actually have a much more meaningful discussion there, because you're not having to talk about other things about hey, reminder to fill this out, or reminder to check your whatever the case might be. Chip,
yeah.
What are your thoughts there? I mean, well, this is awesome.
Well, I have a couple things. The thing that I like most about Dr. Warner's plan, and to be clear for everyone listening, we're going to come back in a couple weeks and hear from Dr. Warner about how it's gone, and what parts have gone well, what parts have not gone well, what the surprises have been, and so forth. But the thing I like about it most is that it's a very conscious effort on her part to meet her patients where they are. One of the problems I see in a lot of pediatric practices is that if you're a doctor today, and you're in the middle of your career, you are not 25 years old. You're not 20 years old. You're not the age of your patients. And the more established you are in your career, and the better you are at what you do, the further you are away from the very people you serve. And I think what Dr. Warner has done here is identify a way to get into the very world that her parents live in. And Dr. Warner, please correct me if I'm getting any of this wrong. Okay, don't just shake your head, say you've got it right or you've got it wrong.
Well, that and the teens too, because you have a teenager. How was school today? Fine. What'd you do? Pretty much nothing.
Yeah.
That's to me the ultimate beauty of this. So yeah, of course, I think
too distant future that teen, which is not very far away, is going to be a parent. I mean, in a blink of an eye.
No. We're talking about my kid now. That's 10 or 15 years from now, easily. Come on. But the fact is, it's so. We could talk about other methods for doing this, and we will. And we are going to very specifically also talk about the method that she used. But what I like about it most is that, the teens, the most beautiful part of this is now she's communicating with them and engaging them in a way that they understand. I think that's the most amazing part of this. Now, I also think it's cool, sort of the effort that Dr. Warner has made to make this all happen. She went out and logoed up and got this really cool app, and to say I helped is absurd. Dr. Warner did all the work, and then just every now and then would say, hey, oh, by the way, what do you think of this? Her point system is really cool. I just think it's great, and I'm hoping that we will see her at either the NCE, and we're certainly going to get her to talk about this at a PCC Users Conference. I will say, though, Dr. Warner, I think we have to give credit. Where did you get this idea originally? I mean, besides looking at
your New Year's resolution contest?
Yeah, well, no, before that, like, who did you see?
From the NCE, Todd Woolen?
Yes. Brandon was there, too. I remember being in the room watching Todd Woolen do his talk about the gamification of the practice and thinking, like, how did I never think of this? Why, I should have thought of this a long time ago. So I think you've just taken his concepts 10 times further.
Yeah, absolutely.
But let me ask, though, is there a place where our huge listening audience can see this in action? I mean, I know you've done a couple YouTube videos, but can they see anything on your website, or will they be able to soon? I'll ask that.
Yeah, I can put it on the website, which should be my new website. Yeah. Well,
at some point then, when you get that ready, when we release this podcast, this videocast, we'll put a link to it so people can see how it works.
All right.
Hey, Chip, one additional thing that goes along with kind of the drum that we beat here about the independent physician that I think is another area that we are not pointing out. But I don't think if you would be part of a large organization, if you would be part of a large family family physician group or Doctors Without Work, and I'm not knocking them. I'm not saying that that's a bad strategy, but there is value. Basically, is what I'm saying is that Dr. Warner got an idea, and she started implementing it because she could. I've known practices that they've been deciding, because they're a larger group, they've been deciding on which EMR to go with for like the past 4 years because they haven't been able to decide on which is the right one. Could you imagine that group deciding on an app to do this sort of thing? It would never get off the ground. So I'm not knocking the larger groups. I understand their benefits. I understand the synergies. I understand perfectly why they are there. But I just do also want to highlight the value that you have as a solo or just a small practice to be able to do the cool things that nobody else can do. That what Dr. Warner is doing, she doesn't care about the retail-based clinics, right? That's not even an issue with her on how people were talking about and being threatened by all that stuff the other day on SOPM when people were saying, we need to do something. The AAP should defend us and write a letter. Whatever. Yeah, fine, they should. But the people that go to Dr. Warner's practice is not, when they have things like this, their first thought is not go to the retail-based clinic.
Yep. So Dr. Warner, I'm going to ask you. You're going to formally start this process when?
Monday.
Okay. How long from the moment you decided to start working, or from the moment you did start working on this project until today, how long has it been? How long did it take you to take this idea from concept to reality?
2 months.
I'm sorry?
2 months.
Hey, Cameron. That's Dr. Warner's son. So 2 months. And how large a staff do you have to help you work on this project?
So far, I've done most of it, but I've got one staff member.
Okay, so you, as a solo physician, went from concept that no other practice in the country I've ever seen has in place to reality on your own in your spare time, and you've gone and done something that's the largest practices in the country don't do.
Well, I don't have all the administration to tell me you can't do this.
Yes, that's exactly the point.
So you could, this sounds absurd, but you had an idea, you had a dream, and you made it happen because you're your own boss.
Correct. Yep.
All right. That's the adventure. Now I'm just curious, are there any other aspects of your practice now that you could not have brought to reality because, in any of your former roles? Is there anything else that you do that you associate with being solo?
Well, the vaccine policy is one. I think in a larger group, you're not going to usually get that type of ability to make that decision. Practice hours. I come in whenever the patient needs me. If it's after hours, I'll just meet them here in the office, trying to keep them out of urgent cares in the emergency room. And I don't think you can do that in a bigger group.
Okay. I mean, that's the sort of thing I expect to hear. I just want to. It's just always great to confirm something that you know the answer to. It makes you seem happy and smart. All right. So, Dr. Warner, do you have to take a phone call? I heard.
No, we told him to call back.
Oh.
Cameron answered for me. He said, he told him to call back in about 15 minutes, so we're good.
Okay. He said she's doing something very important, and the President of the United States is on the phone.
Yeah, exactly. He can call back. He can call back during her break.
All right. So in a couple weeks, Dr. Warner, we are very much going to ask you back, and I'm really hoping that you share more of the details with this on SOPM and in a few other places, because what you're doing is just proof that the sky is not falling, and and sort of supporting what Lynn Kramer told me once. She said, if I had $1 for every time someone told me I couldn't do something and then just did it, I could retire, and you're a good example of that. So I'm appreciative of your effort. Your results are just icing on the cake. So before we go, Brandon, is there anything else that we need to add to today's discussion with Dr. Warner in the room?
No, I'm looking at my notes here. No, I think it's worthwhile that you still have some of those seminars coming up. I think those things, definitely are something that if you haven't signed up, to go sign up. There's 2 seminars, right, that you're going to be doing?
Yep, and I know. Dr. Warner, where were you just 2 weekends ago or 3 weekends ago?
I was in Tampa.
And you saw the Practice Management Institute seminar.
Yeah. Uh-huh.
How was it?
It was excellent. It was great.
All right. Was there anyone in particular who was good? I'm just curious.
Be careful. Be careful with what you say.
Right. You won't be invited back if you answer that question wrong. So Dr. Warner was there. We had a pretty solid room. Things were great. We have 2 more events. One in Rochester in a couple weeks, and one in April in Dallas. And then we've got the California Chapter 1 also in April out in Lake Tahoe. My attendance at these things has no bearing in my interest in having people go to them. Well, I mean, it increases it, but I think my minimum standards, I really want people to attend more training. Dr. Warner is great about this, and it's that kind of upward vision, the same sort of personality that gets her in at these seminars is the one that helps her develop these really cool systems like she's done. So I think that's great. So thanks for asking.
Seminar without listening to Todd Wolin, she would have not come up with this idea. So who knows if you go to this seminar in where is it? Rochester and Dallas, you could hear something that could transform your practice. Right?
Yeah, I think it's great. Dr. Warner, do you have anything else for us that you'd like to tell our audience? Now's your chance.
I don't think so.
All right. Well, thank you, everyone. I appreciate it, and we will speak to you soon.
Okay.
Thank you again, Dr. Warner. I really appreciate it. It's great you made it. All right, toodaloo.
Bye.